Hello, everybody, and welcome to our webinar, Hereditary Angioedema, HAE in Plain Sight. I'm Dr. Volha Skrahina, Vice Director Clinical Studies, and today, together with me, the webinar will be introduced to you by me and two my colleagues, Dr. Aida Bertoli-Avella, Head of Research and Data Analysis at CentoGene, and Dr. Selen Zülbahar, Clinical Project Manager and Team Leader, Hereditary Angioedema Project Lead in CentoGene. So thank you very much for coming and for your attention. So today we will introduce you to the following topics. As a reminder, we will introduce you to complement and contact systems and to hereditary angioedema genetics, which will be followed by Dr. Aida Bertoli-Avella, and she will tell you about the hereditary angioedema clinical manifestation. Then we move to the biomarkers in hereditary angioedema field and treatment of this disease. And then Dr. Selen Zülbahar will introduce you to current clinical studies that are done in CentoGene and are dedicated to hereditary angioedema topic. So complement and contact system. So complement system is a part of our immune system. There are well-known 3 pathways. We will not focus on them. There are more than 20 proteins that interact between each other, and the idea is to eliminate their pathogens. So proteins are inactive in a normal state, and they are getting activated in the enzyme cascade during response to infections. And these processes have to be tightly regulated, as it might be damaging to the host tissues when they are activated not in response to infections. The contact system are plasma proteins, then again responds to the presence of pathogenic organisms, and the key features are factor 12, factor 12, factor 11, plasma karikline, high molecular weight kininogen, and C1 esterase inhibitor. So upon activation, the system triggers blood coagulation and is responsible for the generation of pro-inflammatory products. So it's also important that this system is tightly regulated and only activated in response to infections. C1 inhibitor, a protease that inhibits the complement and contact systems, both of them, to prevent spontaneous activation. So as also depicted here, so it's one of the major regulators. Hereditary angioedema genetics. So hereditary angioedema disease is autosomal dominant disease characterized by recurrent episodes of subcutaneous and submucosal swellings lasting from 2 to 5 days if they are not treated, and involving mostly the swellings of extremities, face, airways, and gastrointestinal tract. As with all rare diseases, the prevalence is not really known, and depending on the literature, it stays from 1 to 10,000 to 1 to 50,000. And we have done our own investigation in CentoGene, and we saw a country-specific pattern. So in Turkey, 1 in 17,000, and in Germany, 1 in 36,000. So the diagnosis of this disease is delayed from about 8.5 years, and it's usually because of the misdiagnosis, and this results in the necessary treatments and medical interventions. And for sure, this disease has a great impact on patients' family, personal, social, and mental well-being. So 80% of hereditary angioedema cases come from the variants, pathogenic variants in a SERPIG1 gene, which are inherited in autosomal dominant manner. There are more than 450 pathogenic variants being described in SERPIG1 gene, and 20% of them are de novo. So SERPIG1 encodes for, just introduced to you, C1 inhibitor protein, and it's the major inhibitor of both complement and contact system. And depending on the pathogenic variant in the gene, it could lead to the protein deficiency or to the non-functional protein. So the protein will be there, but the conformation will be wrong and it will be not active. So, and there are also other causes of hereditary angioedema, and one of them are the variants in the factor 12 gene. So far, there are 4 types of pathogenic variants being described in factor 12. So factor 12 is a part of coagulation cascade and activates factor 11 and prekallikrein. And in case of the pathogenic variant in the factor 12 gene, their phenotype is mainly seen in women, as factor 12 is sensitive to estrogen exposure. The other rare cases of hereditary angioedema come from the pathogenic variants in the plasminogen gene. So far, 2 types of pathogenic variants were described in this gene, and plasminogen is an inactive precursor of plasmin, protein serine protease, which is involved in dissolution of fibrin blood clots. So 80 patients were identified with a pathogenic variant. It's also inherited in autosomal dominant manner. And the cohort description of this patient revealed that they mainly have tongue swellings or face edemas. Another example is the angioprotein gene. It's suggested to be also autosomal dominant disease, so the variants in the angioprotein gene. Angioprotein, only so far 1 family was described. So angioprotein is a secreted protein which works in a complex with other protein type 2, which is a receptor primarily expressed in a growing vascular endothelial cells. And this complex is essential and stabilizes the blood vascular endothelium and regulates the barrier function. So in the variant this was described, the stabilization of the complex was in the end not proper, which results in angioedema, which is bradykinin mediated, as well as in the other examples. So the next one is hereditary angioedema that is caused due to pathogenic variants in the kininogen gene. Only so far 1 family was described with the pathogenic variant in this gene. The kininogen gene codes for kininogen 1 protein, which is a precursor protein to high molecular weight kininogen, low molecular weight kininogen, and bradykinin. So the described variant changes the N-terminal cleavage site of the bradykinin from high molecular weight kininogen to low molecular weight kininogen, leading to functionally active but aberrant bradykinin. And the same clinical features were described in this family. Now I move to Dr. Aida Bertoli-Avella, and she will introduce you to hereditary angioedema clinical manifestation.
Hi, welcome everybody. It's very nice to be here today. Thank you to my colleague Volha for this nice introduction of the first part of the webinar. So I'm going to describe briefly some of the main or the most relevant features of the clinical manifestations of this disease. Hereditary angioedema is a very rare genetic disorder. It's characterized by several clinical features that we are going to describe today. It's mainly the main or the more prominent feature are these recurrent attacks or episodes of edema or swelling that is affecting the face, the arms or hands, feet and legs, and also the trunk. And it can affect the upper respiratory airways and also the gastrointestinal system. The disease has reduced penetrance and has also a variable clinical expression, and of course also a variable age at onset. Most of the patients start with the symptoms from the first decade or till the second decade. And this is where most of the patients start with the manifestations. The frequency of the attacks is also very variable per patient. These attacks are also triggered by many different factors. Some of the most known are trauma or medical procedures or dental procedures, stress, infections, menstruation, or other hormonal fluctuations. The disease, as we mentioned, affects or produce this edema that is including the submucous and subcutaneous layers, and it can present in very different parts of the body. These attacks, if they are left untreated, can resolve spontaneously in 2 to 5 days. The edema in this disease is typical, and it should be differentiated from other diseases that are also causing edema. The edema in this disease is non-pitting, is non-pruritic or non-pruritic, and it has well-defined margins. It's usually affecting, for example, the lips or the eyelids, and also, for example, in the mouth, the tongue. A very severe presentation is the fearsome laryngeal edema. This, of course, can lead to death of the patient due to asphyxiation. There can be also edema in the nasal and the sinus regions in the upper airways. And later we will talk in the next slide about presentations in the gastrointestinal system. During some occasions, also edema can occur in the genital area due, for example, to intercourse or due to delivery. There are some fissures that can announce the presentation of the attack, so what is called as a prodrome fissures, and this could be, for example, a certain type of rash that is called as, or is known as erythema marginarum. And there are, for example, symptoms like fatigue, or the individual gets very thirsty, or feels really unwell. These are all features that can tell the patient that the attack or one attack is coming. We pass to the next slide. So we were talking already about different places where the edema can occur. This graphic is from a paper from Borg et al. They published in 2006, and they did a study of about 220 patients that presented these manifestations, and they followed the patients from a period of time, and they recorded every attack, did different characterizations about the clinical presentation. The most affected organ or manifestation is in the skin, so edema that is affecting the skin in different parts of the body. The second most common presentation is affecting the stomach or the gut, so the gastrointestinal system. From here, this is also important system that we should consider because of the presentation with severe pain, sometimes only or isolated, and this could be a serious, can pose a serious problem for diagnosis of the patient. Other localizations are the larynx, the uvula, the soft palate, the tongue, and the most rare in this case was esophagus. Patients with edema affecting the esophagus are describing this as a very, very painful experience, especially when swallowing is done. And again, the pain takes several days. So in the gastrointestinal tract, as we said also from the slide before, a large percentage of the individuals are presenting this as unique manifestation. It's a recurrent abdominal pain. In many cases, it's very difficult to reach the appropriate diagnosis. Also, this pain is in some occasions accompanied by nausea or vomiting or diarrhea. The pain can be really severe, so severe that sometimes doctors are bringing the patient to surgical procedures that are not necessary. So it's really a misdiagnosis. And this slide is a short summary of the duration of the abdominal pain. So, for example, we see here that in the first day, the pain is worsening during the first hours. Then it's getting worse and worse. There is a period in the second day that the pain reached the maximum intensity, and then usually after the second day, beginning of the third and fourth day, then the pain goes down. And then there is finally relief. So now I give the word back to my colleague that will continue with the section of biomarkers.
Thank you very much, Aida. So I'm proceeding now with hereditary angioedema biomarkers. And Centogene is well known in developing biomarkers, and everything what is needed for that is a completed dry blood spot filter center card, where less than half of milliliter blood is required. And this card is used for both genetic and biochemistry analysis. And this is just a wonderful example that was well established in Centogene. Here we mentioned for sure another disease, Gaucher disease. And here we see one patient that was follow up every couple of weeks from 2011 till 2016. So this patient is a Gaucher patient on the enzyme replacement therapy. And every couple of weeks, the patient was given blood. Blood was applied on their Cento filter card and sent to Centogene for the biochemical analysis. And we were measuring lyso-Gb1 level, nanogram per milliliter in blood. And here we see that the patient was responding well to their enzyme replacement therapy, 45 units per kilogram. But after a while, the bone crisis takes place and the enzyme replacement therapy needs to be adjusted, because the level of the lyso-Gb1 biomarker directly correlates with the phenotype, with the severity of the phenotype of the patient. So this is a classical biomarker, lyso-Gb1, where we can measure the level, thereby diagnose the patient, but we're also able to monitor the patient and to individualize, personalize the treatment for the patient. And this in Centogene was already published and developed for other diseases as Farber, Neumann-Pick type C, and Fabry disease, lyso-Gb3, but this biomarker is for sure mainly indicative for male patients due to their X type inheritance mode. So hereditary angioedema, the nature of disease, these unpredictable attacks for the patients, really requires a biomarker that would be able for sure to diagnose the participant, but would be also able to predict the attack and maybe personalize the treatment in the area where there are various treatments available for this disease. I will introduce it later. And there were already several attempts, and some biomarkers are already published for this disease. And the majority of them are diagnostics biomarkers. So as C1 level, C1 activity. So activity is really necessary in the hereditary angioedema type 2, where the protein is there, C1 inhibitor, but there is not active due to their mutation in the SERPING1 gene, which leads to not the proper conformation. Measuring the level of C1 and C4, the activity of C1 are diagnostic biomarkers. So seeing the values of this, the disease can be diagnosed or not. And also there are other biomarkers which measure the direct complexes as prekallikrein high molecular weight kininogen complex as a diagnostic biomarker, and activated factor 12 in a complex with C1 inhibitor level. So there are several attempts to create a biomarker that can predict and monitor an attacks. So one logical example that would come is a bradykinin level, because bradykinin level directly correlates with the attacks. However, to measure the bradykinin is really challenging in the laboratory. So far there is no established method how to exactly measure the bradykinin level. So there were also attempts to create bradykinin, to measure bradykinin breakdown products as pentapeptide. There is a commercial kit available for that, but there are debates if this kit is really addressing the question in the literature. Cleaved high molecular weight kininogen that we are also following up in CentoGene, and for example, plasma kallikrein alpha-2 microglobulin complexes level that can follow up an attack of swelling. So these are our CentoGene and published data. And here we measure directly from dry blood sport filter CentoCard the cleaved high molecular weight kininogen level in a control groups and in hereditary angioedema type 1 and hereditary angioedema type 2. And we do see that the level of cleaved high molecular kininogen is increased in comparison to our controls. Moreover, we addressed the same question when we have our control group, hereditary angioedema patient that did not receive the treatment and hereditary angioedema patient that undergone the treatment. And we measured cleaved high molecular weight kininogen in these three groups, and we do see the significant difference in level of high molecular weight kininogen in comparison in higher untreated group in comparison to group with hereditary angioedema disease under the treatment versus and controls. Currently, there are two types of treatment for hereditary angioedema disease, and here is represented on-demand treatment, meaning this the patient starts feeling the swelling and immediately starts the treatment. So to on-the-demand treatment, we have a human plasma-derived C1 inhibitor produced by two companies, also rabbit recombinant C1 inhibitor and kallikrein inhibitor and bradykinin receptor antagonists that are produced by several companies. And human plasma-derived C1 inhibitor could be also used prophylactically and easy use, so obtained on a regular basis in order to limit the amount of attacks that patient is suffering from. And there is a new medication on the market, which is an antibody. It has a different mechanism pattern. So this antibody binds directly plasma kallikrein and performs direct inhibition of active plasma kallikrein and thereby limits the bradykinin production. And this medication is prescribed prophylactically in order to limit the amount or even not to lead to their spontaneous swellings that patient can obtain having the hereditary angioedema disease. And now I would introduce you to Dr. Selen Zülbahar that would tell you about clinical studies at CentoGene that are dedicated to hereditary angioedema disease.
Hello, everybody. So thank you very much, Aida and Volha, for the very nice introduction of the HAE disease. So I'm going to give you a brief overview about the HAE-related clinical studies sponsored by CentoGene. So we have in total 3 clinical programs about HAE. The first one is called Epidemiological Analysis for Hereditary Angioedema Disease, or in short, EHA study. So this is an epidemiological, international, multi-center, and observational study. So you already heard from Aida that the abdominal symptoms or of HAE are very common symptoms observed in about 93% of the patients. And in rare cases, it is the first and only manifestation of disease. And EHA study targets exactly these patients who represent repetitive abdominal pain attacks of no obvious etiology. In this study, we mainly work with gastroenterology, emergency and gynecology departments, because these departments are potentially the departments seeing such patients at first. We aim to enroll a total of 5,000 participants in this study, and participating countries are currently Mexico, Germany, Italy, Turkey, Poland, and Japan. And the first patient was enrolled in October 2018. The inclusion criteria for this study is as follows. So an informed consent should be obtained from each participant, or if it is a pediatric population, from the legal guardian or parent. And participants should be suffering from repetitive episodes of abdominal pain attacks without a determined etiology, and the age range is from 2 years to 60 years old. And exclusion criteria is accordingly the opposite of this. So inability to provide informed consent if the etiology of the abdominal pain attacks is determined, if the participant is not within the age range of 2 to 60 years old, and if there is already a diagnosis of HAE. So in this study, our primary objective is to investigate the prevalence of HAE in participants with previous episodes of abdominal pain of no obvious etiology. And as a secondary objective, we want to analyze the HAE positive cohort further biochemically for identification of new biomarkers. And the workflow in CentoWebinar is as follows. So we receive the blood sample of the participant on the dry blood spot filter card, the so-called Cento card. And in the first step, we do the biochemical analysis. So we measure the complement C4 and C1 inhibitor levels, and as internal controls C1q and complement C3. And if we see anything pathological in this step, we proceed with the genetic analysis, where we sequence the SERPIN-G1 gene. And in case of a normal sequencing result, in order not to miss Dutch deletions and duplications, we additionally perform the deletion duplication analysis. And according to the genetic results, the physician, so the treating physician of the participant, receives a medical report from us, an online report. So we already have over 1,000 participants enrolled in this study, and we performed an interim analysis of first 1,000 participants. And during this period, recruiting countries were as follows. So Germany, Italy, Turkey, UK, Poland, and Japan. And within this 1,000 participants, we identified 3 participants with HAE disease. So this brings us to the preliminary calculation of prevalence of HAE in this cohort, which is 0.3%. And we additionally screened the family members of positively diagnosed participants, and we could identify 10 additional HAE patients. And if we include this screening of the family members in the prevalence calculation, then we end up with a prevalence of 1.3% in such a cohort, which already indicates the importance of family screening, so genetic screening of this disease. So the second study sponsored by CentoWebinar is called Biomarker for Hereditary Angioedema disease, or in short, BioHAE disease. This is also an international observational and multi-center study, which includes the longitudinal monitoring of the participants. So, in this study, the study population in this case is diagnosed patients, so genetically diagnosed hereditary angioedema patients, and we aim to enroll a total of 1,000 participants worldwide. So, we can include study sites from all over the world in this study. And inclusion criteria is as follows. So again, an informed consent should be obtained for each participant. The participants can be participants from 2 months old to 60 years old can be enrolled. And as a preliminary step, each participant should be diagnosed genetically by Centogene. So potentially in this study, you can start with highly suspected participants, which can then be enrolled upon genetic diagnosis by Centogene. And therefore, exclusion criteria is the opposite. So if the participant is not able to provide informed consent, not filling in the age criteria, and if the diagnosis of HAE is not confirmed by Centogene. So in this study, our primary objective is to identify, validate, and monitor mass spectrometry-based biomarkers for HAE disease. And in the second step, we want to test the clinical robustness, specificity, and the predictive value of such biomarkers by longitudinal monitoring. And the duration of the study is 36 months per participant. So which is as follows. So participants are enrolled during the first visit, and they are expected to visit the study site every 3 months for a total of 36 months. So ending up with 13 visits in total. And to identify and validate novel biomarkers, we use the liquid chromatography multiple reaction monitoring mass spectrometry method. And in this method, so we analyze all the metabolites in the blood samples by grouping the samples into different categories. So in this case, the different groups are the HAE patients on treatment, HAE patients without treatment, and compared to healthy individuals. And age and gender is also considered while grouping the samples. So again, to summarize how the study works, so prior to enrollment of each participant, a blood sample will be sent to Centogene to confirm the HAE diagnosis, and an online report will be shared with the physician. And then physician can, in the next step, enroll the already diagnosed participants. And in this step, an informed consent for the study should be obtained, and the blood samples will be sent in a pseudo-anonymized way. So the participant ID replaced by the so-called CG number. And in this step, the diagnostic tests will be repeated and then followed by biochemical analysis for biomarkers. And in the third phase, which is the follow-up phase, so the participants will be visiting the study site every 3 months, and a sample will be drawn each time, and this time analysis will be done only for biomarker candidates, and the physician will no longer receive a medical report. And the workflow at Centogene includes measurement of complement levels followed by genetics by analyzing 5 genes, the so-called HAE panel, which are known from the literature to be associated with HAE disease. So they are SERPING1, factor 12, plasminogen, angiopoietin-1, and kininogen-1. So the workflow is similar to the other studies. So blood samples are always applied on the dry blood spot filter card, sent to Centogene. And at Centogene, they are analyzed first biochemically by measuring the levels of complement C1, C4 and C1 inhibitor. And in this step, irregardless of the results from biochemical tests, we perform the genetics because we are aware that these complements level can be sometimes affected by the treatment. And in the HAE panel, so the 5 genes will be checked for mutations, in addition for deletion, large deletion and duplications, and online report will be shared. And the third study is called Hereditary Angioedema Kininogen Assay, or HAE study. This is also multi-center study. however, only performed in Germany. So in this study, study population includes HAE patients, HAE type, but only type 1 and type 2 patients, and we aim to enroll a total of 100 diagnosed HAE patients, and 50 of them should be on lanadelumab treatment, and 50 of them are without treatment. So, and duration of this study per participant is expected to be 30 months, again with follow-up visits. And inclusion criteria is that informed consent is obtained from the participant, and participant is diagnosed with hereditary angioedema type 1 or 2, and the participant must have experienced at least 4 HAE attacks within the last 12 months before enrollment. And only participants older than 18 years old can be enrolled. And exclusion criteria is accordingly the opposite. So participants which have experienced less than 4 attacks cannot be enrolled. And in the primary objectives of this study is to, first of all, explore the cleaved high molecular kininogen level. And along with that, we also aim to identify and analyze new biomarker candidates. And we also want to compare the treatment versus non-treatment patients, and to validate the biomarkers. So the study flow is like that. In the visit 1, the genetic confirmation of HAE type 1, 2 is performed. And then during the follow-up visits, biomarker candidates are analyzed. And novel feature of this study is that HAE attacks are also documented by self-sampling of the participants. So we provide kits to the participants, and we ask them to draw blood samples through safety lancets whenever they feel like an attack is approaching, and during the attack, optimally with 3 hours of intervals, and also after the attack. And as I said, mainly we investigate the cleaved high molecular weight kininogen as a biomarker, and also analyze other biomarker candidates in the samples. And we want to, through the candidate biomarkers, we want to also observe the impact of treatment, lanadelumab treatment on patients. So yeah, this self-sampling by participants. So the kits were designed in a way that the sampling is made very easily by the participants. So this kit includes safety lancets, ethanol pads for disinfection of the sampling area, cotton pads, 6 Santo cards for each attack, and a CRF that can easily, so a case report form that can easily be filled by the participant, and a pre-labeled stamped envelope. And we have done a preliminary survey about the feasibility of this sampling method, and participants find it quite find it very convenient and well accepted. So they were rating most of the steps of the sampling as very good. And in this study, we have documented already 9 attacks with a total of 42 samples. And here there is a example of dry blood spot sample collected by a participant successfully. And we performed all proof of concept analysis. So we measured, so from these attack samples, we analyzed the C4 levels, which is a well-known biomarker, and we could very well observe the significant decrease of the C4 levels during the attack, and an increase again towards the end of the attack, proving that such an approach is acceptable and valid approach for analyzing the biomarker candidates. So this brings me to the end of our presentation. So thank you everyone for joining our webinar. We hope you were able to gain some useful information about HAE disease and the clinical studies at CentoGen. So you will receive a follow-up email from us with a link to the webinar, and there you can contact for clinical studies. So we are going to launch a poll now to receive your feedback on the webinar. So please be so kind and take a few minutes to fill it out. And yes, if you have more questions, we are happy to get back to you via email. So thank you once more and have a great day.